Hey guys, welcome to my YouTube channel. Today we are focusing on the lower limbs. Thank you. We're going to start with the knee. So you have to take both knees, the marker on the right side. Some people prefer one, I do two. Your toes must be turned internally so that your patella is in the middle. We're doing two so that we compare, remember. And you center there by the patella. I was feeling the patella because now I couldn't see the knee because my patient is wearing a long trouser. My patient was sitting, but most patients should be supine for their comfort. If they want to sit, it's fine. Don't forget the apron, half apron. You see there the joint is opened, the condyles are nicely equal distance, the patella is centered. Now this is the lateral knee, oblique knee. See, with the x-rays, the patella is externally. Remember, you turn your toes outwards, and then you see your fibula shifted laterally to the tibia. For your internal oblique knee, you have to turn your toe inwards, and then that will show your patella, shifted internally as well, so the condyles will no longer be equidistant to each other. The joint should be open. So for the lateral, I asked my patient, okay, how about we do the other side for content, obviously, and then she agreed. So please don't forget, you have to angle your knee nicely. So, oh my gosh, I've got the angle. I will get it. I will look back to my books, but I just know how to do it properly. And don't forget, your CR must be 7 degrees tilted upwards so that your joint is open, because the condyles, remember, they are not the same height. So if you don't angle, you're not going to get this joint, and that's going to be tilt. And the patella must be perpendicular to the IR so that there's no rotation. We're going to talk about that when we do criteria. Now we're doing the ankle. Don't forget to dorsiflex your right mark on the right side. You see there the fibula and tibia, they're superimposing, For the medial oblique, you turn your toes inwards, you dorsiflex, very important for the joint to open. You can put your sponges in for support, and that is going to open the joint there between the talus and the fibula. The dorsiflex part is gonna open the motifs there. For the lateral oblique, toes laterally, don't forget your immobilization. If you need support for some patient, don't forget your dorsiflex, making your toes up. And that opens the joint. Don't forget your marker. And then you center there by the malleoli, the medial malleoli. Guys, we're going to talk about the criteria. And then, this is the image. This is the image that we get, where you see the joint there, the ankle joint is open. And then for the foot, remember, we angle cephalate with a specific degree. I will also confirm, but that is for because your feet is slopey, so that it can be parallel with your foot slopeness, so that the joint there by the tassel will be open. But lately you just work with your experience. So for the medial, for the oblique, I mean the foot oblique, you turn your foot in, your knee in, and you put support there. So this will show the oblique part. Don't forget the calcaneus, guys. Take it, like pull it out slightly to the right if you're doing the right one, nicely, so that it doesn't superimpose. So now we're doing the lateral. With the lateral, your knee should not be flat, because we want, you see there I was putting my patient's knee up, because we want the superimposition there by the, what's the word, by the longitudinal arc. Oh, nice. And now this is a view of your standing foot. We do standing, we do supine, depending on what is requested, depending on the indication of the patient. So now there's a lower leg. There's a lower leg. A lower leg is the same as a ankle and a knee. It's just that you put them in the same cassette. You can do it with the portage, you can do it with the diagonal. With the portage, you're going to do two views, upper and the lower, same, but you're going to center differently. You're not going to center by the knee, you're not going to center by the ankle, you're just going to center where the included part meet. So this lateral as well is the same as the AP knee, the lateral is the same as the lateral ankle, lateral knee. That is radiography. Whatever you have done, just combine the two. That's what I always tell my patients. If you know the ankle and the knee, you know the lower leg. If you know the ankle, the knee and the hip, you know the femur. Anything of a long bone, you know it if you know those other positions. So guys, I hope this is more in detail. I hope you will understand, especially if there's students who are going to check this video out. So don't forget geopatella perpendicular to the IR. That will always help your rotation, or else you're going to have a rotation. So we're also going to be talking about how to correct your rotation. That is something that I'm so passionate with, because we don't want repeats, right? We don't want repeats. So this is what am I doing now? So this was the upper part of the lower leg. You see the center is just below the knee. Yes, don't mind me, guys. Don't mind my child next to me. She's sleeping, so I don't have time to do this voiceover in the morning or at work or during the day. I got the time now while she's asleep, and I'm like, let me do it. So this is the image of the lateral and the AP of the lower leg. I don't like this image because it doesn't include much of the ankle. It doesn't include much of the knee. Yes, you should include the whole knee, but guys, no, this is important. Like, I feel like it's cutting the joint. Okay, now we're doing the hip. There I was feeling the iliac crest, gently so, because the iliac crest will direct me where to put how many fingers above the iliac crest. So if in case I want to include the iliac crest, so if you want to include the iliac crest, go about like 4 fingers or 2 or 3 depending on the size of your fingers. So you see here, I bet they did not put any fingers above, but it's fine because it's a hip. But for pelvis, please, it's important. That is very important. So this is the lower part of the femur. That was the upper part of the femur. That was also AP hip. That was also AP proximal femur, right? So now, again, an image that is so nicely so, but I don't like how they cut in the joint. I don't like that part. I would not accept that image. So this is a lateral distal part of the femur. Remember, distal is away, proximal is nearby you. So as you see, this is so nicely. So the thing about lateral is that you're gonna get nice contrast, and then there by the hip it just becomes so bad, because remember the thickness is not the same, guys. From the knee to the hip, there's a difference in soft tissue thickness. So now this is the part that I like, the hip. I've realized as I walked along the ears that when you position the hip, the soft tissue goes lateral, like goes to the side, and the hip, the bone is just left there medially. So when you position, just go to the medial side a bit. Don't center it right, don't center mid. What is this? What is this mid coronal? What is this of the hip? Is it coronal? Yeah, it's coronal. So because the soft tissue is gonna lie there, you're gonna only see the soft tissue and not the bone, depending though on the body of the patient. If the patient is big, do that. If the patient is a thin patient, don't do that. So this is the pelvis, where this is a nicely so pelvis. Electors included. Thank you very much. This voiceover is so difficult. The video are going so fast. Yeah, but thank you. Bye. Thank you very much. I hope you enjoy.